Just to mention, you might have all heard that this meeting is being recorded. We will be sharing the download and video of the session with the slides after the call. So yeah, thanks for that. So first of all, some housekeeping. So just please keep your mics off during the session. We want this session to be interactive, so please use the chat box. Introduce yourself in the chat box, that would be great. Share your thoughts, comments and questions throughout the morning. Just for those colleagues that don't know what the Northwest Collaborative is, it's a combination of a number of us in the region coming together, a number of organisations, MIAA, Aqua, the NHS Northwest Leadership Academy, Northwest Employers, and also my own organisation, Northwest ADASS. So that's the collaborative. So if I can also just introduce to you a couple of colleagues on the call that are going to be showcasing some work that they do nationally and also locally within the region. The first person for me to introduce is Chris Naylor from the King's Fund. Chris, I don't know if you want to say a little bit about yourself and why you're here. We just need to remind people that originally Becky was going to be here from the King's Fund, but is not able to join us. So, Chris, can I just bring you in for a quick introduction?
Sure, yeah. Thanks, Helen, and morning, everyone. Yes, my name's Chris Naylor. I'm a senior fellow in the policy team at the King's Fund. I lead a lot of our research and policy work around integrated care, and so it's really great to join you all this morning.
Thanks, Chris. So Chris is up first, then we're going to have a slideshow from Chris with then some reflections on what he's saying from his presentation. And then we've got some discussion to have after that. And then we've got two presentations, one from Sefton colleagues and then one from Manchester colleagues. So Geraldine and Sharon, can I bring you in just for introductions from Sefton and your roles, please?
Thanks, Helen. Hi, everyone. I'm Geraldine Murphy-Walkden. I'm the Programme Director for Better at Home, which is a transformation programme across Sefton NHS and Sefton Adult Social Care.
Sharon?
Thank you, Helen. I'm Sharon Dooner. I'm Head of Ageing Well. I've worked in Sefton within this role for the last 11 years. I have urgent care and community services in my portfolio, and I've been working very closely with Geraldine on our out of hospital offer for the borough of Sefton for the last 12 months.
Thanks both. And then we've got a colleague, Sarah from Manchester as well. Sarah, I think you're on the call if you want to do an intro.
I am. Thanks, Helen, and hi, everyone. I'm Sarah, and I'm the Deputy Director for Adult Social Services here in Manchester. And it's actually great to come back to one of these sessions because we actually did, myself and a colleague presented at one of these, I think a couple of years ago, Helen. I can't remember precisely, where we were talking about our Better Outcomes, Better Lives programme when we were kind of in the earlier stages. So it's great to come back and be able to feed back on where we are now. Thanks, Helen.
Thanks so much. So just before we get into the presentations, just to say and be clear with everybody that the session today is called Making Care Closer to Home a Reality. And it's about refocusing the system to primary and community care, where I think most of the system at the moment, people will agree with, it feels very much like it's in the acute sector. So the health and social care system in England must shift its focus away from the hospital care to primary and community care if it is to be an effective and sustainable system. So during this masterclass, the aim is that we're going to understand why the focus of the system needs to shift to that community and primary focus. explore what is needed to help make this shift and how organisations can equip their workforce to help deliver this vision, understand the underlying factors that prevent the change happening, and what might we need to do to break down these barriers. And then obviously we've got this learning focus from our two areas, Sefton and Manchester. So that's what we're aiming to do today. So if I could now bring Chris in and hand over to Chris for a presentation about the research at the King's Fund. So Chris, you okay to take over?
Yeah, sure. Thanks, Helen. So I think we can go on to the next slide. So I'm going to be joining you to talk through some work we've been doing at the King's Fund on making care closer to home. It's still work that's in progress. So I would say this is not a presentation where I pretend to have all the answers for you. What I'm hoping to do is to give you some material to help stimulate some thinking and some conversations, which we'll then be having in the breakout groups and throughout the rest of the morning. As Helen mentioned, I'm going to be drawing very much on the work of my colleague Becky Baird and other teammates who were involved in a publication earlier this year called Making Care Closer to Home, a Reality, Refocusing the System to Primary and Community Care. And the thing that I wanted to start with from that piece of work was that care closer to home, what do we mean by that term? Well, I think actually it's quite clear that it means different things to different people. So for some professionals, it could be about changing where they work. So we know that, in recent years, we've seen lots of examples of specialists running clinics in GP practices rather than hospital settings, for example. For others, it might be about actually providing different services. So we're seeing community pharmacists, for example, providing an enhanced range of services in a pharmacy setting. For some, it's about changing how different community-based professionals work together. So thinking about that shift to more multidisciplinary team working in the community, multi-agency working. And for others, actually, their focus when they talk about care closer to home or community-based care is about changing how we work with communities themselves and with patients and service users. So trying to move to more of an asset-based approach, making better use of community resources and people's individual strengths. So for the purpose of this session, I think we're talking about all of those things. So it's not only about shifting the location of care, it's also about changing how we work and how we think. And I stress that point about changing how we think. Wes Streeting has used a phrase to describe this shift. He says it's about changing the center of gravity. So the center of gravity sometimes feels like in health and care that it's very much around the hospital, changing that so that it's more about the community. So in part, that's about energy and focus and culture. It's changing what politicians and system leaders and senior management give time to, changing the defaults, if you like. Could we go on to the next slide, please? So I think it's important to acknowledge at the start that we've been here before, haven't we? We've had successive governments over 20, 30 years, all saying that their vision is for health and care services to be more focused on communities rather than hospitals. But despite that rhetoric, the vision is very far from being achieved, I think it's fair to say. And that can mean that I think it's understandable if we sort of fall into the sort of fatalism, cynicism. We've heard this before. I think we need to resist that reflex. This quote is one I really like from a provider leader that was involved in our research, saying, well, nothing is impossible. If we wanted to make it work, you're not telling me that the combined expertise, drive, passion, enthusiasm, and experience of folks in the public sector in the UK couldn't solve this problem. Of course they could. There's also, those of you who read the HSJ might have seen a quote from Penny Dash recently, who's the chair of the ICB in Northwest London, talking about actually if we wanted to move to a sort of a community-based model of care, we've got the staff to do that. We've got, in her view, the sort of facilities and resources we need to do that. What gets in the way is more about organizational inertia and interests. So I guess this presentation is about understanding what those barriers are, starting to unpack them, and thinking about how we might address some of them. If we go on to the next slide, please. So this slide shows why we think primary and community settings should have more of a focus, partly because it's where most of the activity happens, actually. So you can see how much activity happens in community health, in GP appointments, and actually this slide doesn't include social care. It doesn't include dentistry or community pharmacy or optometry. So if anything, this slide underplays the amount of activity that goes on in community settings. And that is absolutely not about denigrating the work that goes on in hospitals. I did want to say that. I've had hospital treatment myself over the last year, and believe me, I'm very grateful for the specialist care that I've had. We all want to know it's there when we need it. But if we don't give proactive, preventative, community-based care the focus it deserves, as a country, our health suffers and will go on needing more and more acute care in the future. If we could go on to the next slide, please. This shows what's happened over the last 5 years in terms of investment. So we've said, for over the last 5 years, over much longer than that we want to grow the community sector. But actually, what's actually happened is that as a proportion of overall spending, investment in primary and community services has decreased over the last 5 years. And we see a similar picture in relation to workforce as well. So there has been sizable workforce growth in recent years, but that growth, most of that growth has been in the hospital sector. And as it stands, the long-term workforce plan will see that trend continue over the next few years as well. Could we go on to the next slide, please? So we published this research report that I referred to earlier this year, back in February, delving into why hasn't this change happened? Why has it proved so stubborn to bring about this shift? And the Becky and the research team involved did lots of interviews, so they gathered perspectives from people across health and social care. They reviewed some of the research evidence from the past 30 years, both from England and internationally, and they analysed some of the national data sets as well. And this slide really summarises what we think the main barriers to change are. So firstly, often there are misplaced assumptions about cost savings. It's often assumed that it'll be cheaper doing stuff in the community. It won't. So the direct costs of providing care in community services may not be very different from the direct costs of providing care in hospitals, actually. If there is an opportunity, it's about the capital and other overheads that can make a difference. And so the only way to release savings in practice is to be able to close hospital estate. And in a health system that already has far fewer hospital beds per capita than other systems internationally, that's unlikely to be happening anytime soon. So at least in the short term, assuming that care closer to home is going to be cheaper is a really dangerous assumption to make. Secondly is what we call this cycle of invisibility. So the way this works, I think, is that there's a lack of political and leadership focus on primary care, social care, community services. That means that there's then less of a drive to collect data on those services, and the data that is collected is often poorer quality, it's not comprehensive. That then means that system leaders don't have the data they need to make fully informed decisions, and so the investment in community services is overlooked and the cycle continues. So it's just kind of less visible in the system. Hierarchies of care exist in multiple ways, I think. So medical ethicists sometimes talk about something called the rule of rescue. And that's the idea that when you ask people, you've got a set amount of money, there's someone who's about to die, and you can either save their life or you can spend the same money doing something which might prevent people from dying in the future, but you can only do one. Generally, people say, well, I'm going to save that person's life in the here and now. And you scale that up to the sort of macro scale, and it's hard not to prioritize immediate life-saving treatment over prevention. Partly as a result of that, the financing of hospital services takes priority for politicians and for system leaders over financing for preventative or care services. And that's also reflected in pay and career progression and prestige. So successful leaders are often encouraged to apply for bigger jobs in the acute sector. Primary and community services aren't always seen as a career destination. So there's not parity of prestige here. Misconceptions about public priorities. So the sort of politics can often make it difficult for politicians to contemplate what they think is going to be less popular decisions. There's this assumption that people will prioritize hospitals over all else. Now, interestingly, when people have done research to test that assumption, it's a little bit more nuanced in practice. So Healthwatch England did some research recently and found that actually at the moment, the biggest issue of concern for the public is primary care services. And also public views about health and social care, they're not static. When you do meaningful engagement with people through things like deliberative events, often you can surface more nuanced views. So sometimes there's a sort of misconception that the public care most about priorities, so that about hospitals, so that's what we should prioritize. The financial architecture, as I'm sure everyone on this call knows, it doesn't support this shift. So the way in which acute trust finances are structured, the high fixed cost base, the reliance on cross-subsidization across different parts of the hospital, interdependencies between services within the hospital, all makes it very hard for commissioners to disentangle hospital finances. And that means when cost savings are needed, it's often easier to take that out of primary or community services, and payment by results adds to that dynamic. There's a short-term approach to thinking about return on investment, which gets in the way. So commissioners often expect new service models to demonstrate financial savings over a short time scale, and when they don't materialize, the new model's abandoned and we move on to something else. We think that we need to be taking a much longer term view and thinking about preventing the need in future for ever more hospitals being built, rather than thinking this is about closing existing services. There are increasingly complex needs out there in the population, and one of the barriers is that the system's just not set up to deal with those needs. So the health and care system was developed in the 20th century is very much hospital centric, with increasing specialism and subspecialization, and pathways organized around single diseases. And then, but when we look at people in using health and care services in community and primary care settings, often they have multi-morbidity. They have complex mixture of health and social care needs, mental and physical health. And the system is just not designed well to deal with that complexity. And that makes it, again, kind of harder to bring about this shift. And then finally, the policies aren't always aligned to the vision. So despite the fact that we've had governments over many years talking about this vision of care closer to home, actually sort of the policies around competitive tendering, the approaches to performance management, which focus on acute sector, aren't aligned with that vision. So if that's why it hasn't happened, if we can move on to the next slide, this is about what we need to do now. So this is by no means the final word. As I said, we're still doing more work on this. But I think the first message is that we need a total change in focus here. So more leadership focus on primary and community health and social care services. We need clarity about why we're doing it. So as I've said, I think the narrative around care closer to home needs to be about improving care, improving outcomes, and ensuring the health and care system is sustainable for the future, rather than a narrative that's about delivering cost savings in the short term. We need to make sure all of those policies, so investment decisions, workforce strategy, financial architecture, performance management, all of that needs to be aligned to the vision if we're going to make it happen this time. There also needs to be constancy of purpose over time. So this shift that the government is talking about is going to need patience. It will need a consistent vision over many years to get this right. There'll need to be differential funding growth, I think, to make this happen. So this isn't about taking money out of the hospital sector now. I think that's not realistic for the reasons I've said earlier. But there needs to be disproportionate investment of any growth monies in primary and community and social care services. We also need to think about equipping the workforce. So we've had this trend for increasing specialization, and I think that needs to adjust to reflect the needs of patients. We still need specialists, of course, but we also need an increase in generalist skills with practitioners able to work in the community and hold risk and enable people to live well in their communities. That includes things like being trained in how to work successfully as part of a multidisciplinary team. And all of our sort of workforce planning and education and training needs to reflect that as well. On devolving responsibilities, I don't think a sort of national blueprint for care closer to home is going to work. I think national leaders need to be devolving responsibilities, allowing local areas to focus on what will meet the needs of their communities. And we suggest in the report that integrated care boards should be held to account for strengthening primary and community health and social care services, not just for performance management of the hospital system. So that's in brief what we think needs to happen. If we advance to the next bit there, so if that's what should happen, what shouldn't happen? I think the first thing is to only do bits of it. So individual policies, levers, initiatives on their own won't miraculously unlock this. We need that total change in focus to finally realise the vision. Secondly, structural reorganisation. So, for example, merging community and primary care with acute trusts. Well, that might be an option in some parts of the country where there's a specific local case for it. But at national level, change of that kind, I think, is probably unnecessary and risks detracting from the focus on change at service level. Organizational integration doesn't always lead to operational integration at team level, and it's the latter that we really need to get right. And I've made this point already about expecting short-term financial savings. So if we move on to the last slide, so here's just a few links to some of the reports that flesh out what I've been talking about. If you're interested in the detail, just to say what we're doing next on this. So in January, we're going to be publishing a piece of work that's really focusing on the kind of policy levers to make this happen. So that will contain our suggestions to national government on what levers are available to them to make this happen. We're also planning some work looking at what does this mean for people working in health and care, for workforce development, for training and skills. Linking back to the point I made at the start, care closer to home is about changing how we deliver care, not just where we deliver it. And actually that adds up to lots of changes for lots of people working in different ways. And we need to make sure that staff have all the support that they need to do that well. So thanks very much. I hope that's been giving you some kind of food for thought. If we advance a couple of slides, so we're going to go and on to the next one as well, please. So we're going to go into breakout discussions now. So there will be a chance for sort of Q&A later in the session, but we thought it'd be good to get you all talking with each other and just have a bit of conversation about what does this look like in your own systems? Where are you on this sort of journey towards care closer to home? What's getting in the way? What's needed in your organization to help make that shift? And then, so we've got about 15 minutes in breakout groups for you to have that conversation. And then we're going to come back together and have a bit of feedback from the breakout groups, please. Doesn't need to be comprehensive feedback, but just sort of some snippets from your conversations, particularly around, what are the actions that you think you could take practically that might help with this.
So I think everybody's hopefully back in the room from the breakout rooms. So I wonder if we do have an opportunity. We've got about 15 minutes for feedback and reflections from the group. So really, if somebody's brave enough to stick their hands up to give us feedback from their group, it would be really helpful to aid the discussion.
Helen, I'm not used to using Zoom that much. We use Teams. I don't know how to stick my hand up, so I'm waving the screen.
Just jump in.
Seriously, sorry.
Kenneth or
Kenny,
or
Kenny Robinson,
Kenny,
adult social care in Whittle. And I didn't know if the groups were going to be facilitated, so I just jumped in with the group and we started chatting a little bit, chatting a little bit, and it was really interesting in terms of some of the feedback from groups we'd never met before, and sort of people in different settings and all of that. One thing that struck to me was about sort of where people have been integrated between adult social care and health, and have either gone into that and moved away from it again, a bit like ping pong, a bit like ourselves in Wirral. You're part of these MDT and some of the things Chris was talking about, integrated working, and suddenly someone pulls you back away from that. And seems like, so for our staff, we'd be going back into that. We haven't got, what I noticed on the call, we haven't got neighbourhoods together in terms of what's a neighbourhood, what does the footprint look like, some aligned in this way, and PCNs and different ways. It seemed people were struggling around that. There was some pockets of where good practice and where we've won staff hearts and minds for some people, and working with some of those principles that have been described. We had that. And then just when we come back into the room, I've never met before a guy called Ollie who works at the Christie at the hospital. I work in the community, and we're just having a discussion, a bit like what Chris was saying before, a bit like sort of saying, well, I'm in the community, Ollie. Does it feel like it's a battle between you and the community all of the time? Is it tin hat time for staff who work in the hospital and all of that? And then when we get together in events like this, you see, we're all fighting the same battle, but sometimes it feels like there's a big wall between us and people throwing things over the wall. I think that relationship thing, and it might be back to, I think Chris described it as like a double bubble type thing, where you need to keep the hospital funding steady is what it is, but invest within the community. And I think that'd take a lot of the tensions away, in terms of what's happening. Sorry, that was just my feedback to
so I mean, the Wirral you went into integrated arrangements, didn't you? And then social care was brought back into the council, wasn't it? And so you've gone through a massive change piece there, haven't you?
We often question the director on that, who's now left, so it's okay to say what his thoughts were. And we asked him about why that happened. Why did we go back? And, one of the things was around the hospital. He felt he didn't have any control over the team being in an NHS setting. When the hospital was saying, look, it's chaos here, we need more help. And he couldn't direct that in terms in the way that he'd wanted to. And I think felt a little bit of the shift that the priorities that the council had were not aligned as much, as much focus on them when we were in an NHS setting. And I think that they were the key strategy decisions around that.
Wow. Chris, any reflections from you on what Kenny said there before bring the next group?
I think that point about relationships is so crucial, isn't it? Because so I guess in my presentation I was talking a lot about the sort of way things are set up nationally actually makes this harder rather than easier. But there is, even in spite of the kind of national architecture, there's still that scope to kind of build relationships across the system, and that's actually absolutely critical, isn't it? Regardless of what's going on nationally, this stuff succeeds or fails depending on the kind of quality of relationships across the system locally, really.
Thanks for reflections, Chris. Thanks, Kenny, for input from your group, and thank you for being brave to be the first one to put the hands up. So have we got a volunteer from one of the other groups to come in and just give us some insight from the discussions from another group?
I'm happy to come in, but Simon's put his hand up though. I didn't know
right,
to do that.
Simon's
Apologies.
very polite. So we'll come to you, Sandra, next, and then Simon, do you want to come in?
I was only going to give a quick overview. We all thought we were special, but then we found everyone's doing some flavour of community integration and working together. So that was sort of Warrington, Rochdale, Bolton, Sefton, and in Wigan we thought we were a pilot. Yeah, everyone's trying it. There was a discussion about where the medical work falls. You know, if you just say this is community care and they're under the responsibility of a GP. Really, it should be patients in the community, but still under the responsibility of a hospital consultant. You can't just shift work. I'd spent my career talking about structures, and this is to Chris's point, and, you know, saying, well, if only we were in one organisation, acute and community, all this would be sorted. And then I've gone to work in Wigan, where it is an integrated organisation, and it doesn't make any difference. You know, I think so. The problems are still there.
Simon, can I just ask, what do you think does make the difference?
Well, I'm finance at core, and somebody in our group said, you know, hospitals are good and employ rafts of coders to make sure they're properly paid for the work they do, whereas community tends to be a block allocation, and somehow, I know Chris talked about differential growth, but that would take 40 years or something to recover, you know, get your community. So somehow we're going to have to pump private, but I don't think we're brave enough. I saw something from Virginia Mason in the States where they've actually, you know, you do a bit more health planning, and you could call it commissioning, but you somehow need to reallocate the money without upsetting the population. Well, that's a personal view.
Yeah. Can I, Simon? Sorry, I should have said. Could you introduce yourself? What is your role in Wigan?
I'm audit committee chair at Wigan, Wrightington, and Lee. So I'm a non-executive director, but previously an executive director of finance.
Right, great. So I probably should have said that from the start. If people could introduce themselves as well, that would be really helpful. Anything else to add from your group, Simon?
I'm frantically looking at my notes, but I think that was it.
That's great. And again, I'm going to just before I bring Sandra in, I'll bring Chris back to sort of just reflect on that a little bit.
Yeah, okay. I mean, I thought that point about bravery at the end there, Simon, was really, really key, because if we're going to start moving resources around the system and doing things differently, there is going to have to be a bit of bravery there. And I wonder if one of the things that will help with this is actually having meaningful engagement with people and communities about it. Because, you know, if we're going to do things differently and we don't talk to people about what we're doing, then that can go very badly, can't it? So, you know, I think that kind of sort of community engagement, community-led approach that I know there's a lot of focus on in Wigan and elsewhere needs to be part of this.
Right. Oh, don't know. I'm getting some feedback there. If people could mute. So thanks for that, Simon. Thanks for your input. Sandra, you still willing to come in and share?
Yeah, of course. So, hi everybody. I'm Sandra Crosdale, Associate Director of Integration in Rochdale, which is part of Greater Manchester. And somebody else has already mentioned Rochdale, so I'm sure that group talked about how integrated we are from voluntary sector through to acute. And that for all of us actually in our group is a really key enabler. So a little bit like the previous comments around integration being a real enabler and working with communities. I couldn't agree with you more, Chris, around that really community-led, system-enabled approach in our neighbourhoods. That's where we're really going to make the difference. The challenge is how we get to that point, and we do that in a way that's really genuine and do it in a way that we kind of put our money where our mouth is as well, and we are able to kind of work and put our funding into that space as well. So lots and lots of challenges brought up by the group that I was in. That constant dynamic, Chris, that you talked about in your presentation between do we save lives or we prevent? Do we put money into prevention? There's absolutely got to be that double running. And I think we talked quite a bit. We had a few from GM in our group, and we did talk quite a bit around also the current financial position being a huge barrier to this, where even if you identify funding that a few years ago we might have been able to shift, at the moment that's about going into a bottom line to support the financial position. So that's really challenging. The challenge of GP collective action isn't helpful in this space. So that just makes it quite difficult at the moment.
So can you just explain that a little bit more, Sandra, to us when you say collective action?
So GP collective action, for those that aren't aware, it could be described as GPs working to rule at the moment and doing the things that they are directly contracted for, which for some of us is causing a challenge in terms of their engagement with our normally established integration routes, actually what they're prepared to test and try and work in a different way. And actually some of the things, because of the level of integration that we would do naturally, because of those relationships that have been built, and acknowledging that there's a bit of give and take in the system, that's kind of quite difficult at the moment because of that collective action approach. I don't know if that helps explain.
Yeah, is that just in Rochdale, or was that with other
no,
other colleagues?
That's wider. Yeah, definitely wider.
That's a great description.
And I think the other dynamic is around the ICS dynamic, and actually if we are going to really shift this, Chris talked about it, I totally agree, around that working communities shifting to our neighbourhood NHS, where lots of us have already got different forms of neighbourhood working. But if we're really going to make a difference, then we've got to bring that decision making and financial autonomy back from centralised ICSs back into localities. And I think for the larger ICSs, that in some areas there's been a kind of centralisation of a lot of things. And actually, if we're really serious about a neighbourhood NHS, that has to shift back, because that's not a helpful way of working. So I think, and there was also, a comment around primary care estates as well, which is obviously in a poor state in many ways, and would need investment if we are genuine around shifting into that space. I think I've covered what we talked about.
Thanks so much, Sandra. And I'm going to bring Chris back in just for some reflections on that feedback as well, Chris.
On the money, it's challenging, isn't it? Because the budget means that there is more money going into health and care because through the budget, but it's probably not enough to do everything we want to do and to do everything that the government says it wants to do over the next 5 years. So how do we make some of these changes in the absence of a big amount of resource for kind of pump priming and double running? I guess a kind of couple of thoughts. Partly that I think we could make better use of the existing money if local areas were given more discretion over how to spend it in the best needs of their local communities. So I think we need to see a shift away from, very narrow kind of criteria from national around how specific pots of money need to be spent and accounted for. And I do agree with you, Sandra, that also needs to happen within ICSs as well. So when ICSs were first set up and made statutory bodies 2.5 years ago, all of the policy documents at that time stressed this idea of what they called the principle of subsidiarity. So yes, we're setting up integrated care systems at this wide geographical level, but we don't need to do everything at that level. We do things at the most local level that makes sense, and we only aggregate up to system level the things, the decisions and the spending that would benefit from that greater scale. And I do think that's been a bit lost in the journey over the last couple of years. So I think we do need to sort of get back to the importance of places and place-based working within systems, and a bit of autonomy at that level. The other thing that I think, in terms of things the government could do to make it easier to make the existing money go further would be to make it easier for people to plan on a kind of multi-year basis. That's something we hear from local leaders all the time, that having more of an ability to sort of multi-year financial settlements would make it easier to make the right decisions and to invest to save and to kind of get more impact out of the existing resources.
Just to come back, Chris, around, well, I just want to say something about the budget, and obviously, the allocation of money to health and care. Actually, most of that money was for health. Actually, a massive disproportionate sort of level of money going to health. I think it was 23.5 billion, with just 600 million going to care, and potentially a lot of that may be children's care, social care. So again, around parity of the funding coming down, it's mostly going to health services rather than care services. Just to pick that point up, I would say that, wouldn't I? From supporting adult social care directors in their jobs. So we've got another 2 groups, I think, that still haven't fed back. Is there anybody in those groups that want to come in and share the insights and discussions? I can't actually, I'm trying to see. Hands up, anybody?
Helen, I don't mind feeding back for our group. I don't think we've fed back.
Great. Aaron, you're wonderful. Do you want to come in and share with us what was talked about in your group?
Well, sure. So it's Aaron Barker, Assistant Director of Sustainable Services at NHSGM. So we had, it's quite strange really, because 90% of the people in our group was from Wigan, and I used to work in Wigan myself, so and almost top the 100%. But I had a great discussion around some of the schemes that was taking place across Wigan at the minute. So the virtual ward piece of work, and some work at the centre in terms of admission avoidance at the front of ED. So some really great work taking place. But I think there was some concerns regarding the funding and the future funding of the models and the schemes that people are putting in place. Felt that they never really get a chance to show the worth before they're pulled. So you set things up, and if they're not having instant results, they tend to get pulled because of funding. So I think some of the concerns around short-term funding, and I know it's already been touched on, it is somewhat of an issue. In terms of other barriers, it's generally around funding flows, so shifting funding from acute into community. Felt also discussion around organisational barriers to make some of this work. Some of the policy and the contracting also needs to change to follow it. I think at the minute, the way it's set up, it's great. The policy saying one thing, but if the contracts and the funding flows don't follow that policy, well, it's never going to work. There was something around as well, organisational development and culture that probably needs to take place, and I know that was already picked up in the initial presentation. I think that's the bulk of the discussion, to be fair, though there was something around workforce as well, and obviously training of the workforce to be able to make some of this work. I think there was some discussion around some of the universities will probably need to have a think about how they get opportunities to work and train out in the community, not just over in the acutes. So I think that was the summary of the discussions, to be fair, Helen.
Great. Thanks, Aaron. Chris, anything to come back from you on that?
I guess I agree with a lot of that, Aaron, and the amount of effort that goes into setting up new services and kind of innovative kind of projects and pilot schemes, only for that then to be kind of to let kind of wither away because there isn't long-term funding for it, or because the immediate impact isn't demonstrable. Honestly, it makes me weep, looking at some of the work that went on in Vanguard sites, in integrated care pioneers. There's so much good work that could have been built on that. I think we've lost the opportunity to do that in some places.
Thanks, Chris. I think I think there's one more group. There might be one more group. Just checking if there's anybody from that group that wants to add anything to the conversation. Julie, do you want to come in? Thank you, Julie.
Yeah, I'll just give a lot of what's already been talked about. But I'm Julie Burrows. I'm the head of commissioning in Tameside. The makeup of the group was a range of colleagues from GMICB. So some of the discussion was around the public health funding in relation to how things are done across and done differently across the GM footprint. Some of the discussion was around obviously the inequity in terms of finance from between health and social care, and the disparity in terms of the budgets and the pressure that puts on adult social care. So any of the work that we do in terms of piloting approaches has to be sustainable, and very often it's not because of the funding. The relationships between health and social care, I was just saying, I've only been in my role for 3 weeks, but try understanding the dynamics in terms of the things that work well or where there are good relationships between health and social care. And that is the case in Tameside in terms of the things that work well is because the relationships between health and social care. There was an example that one of the group members talked about in terms of social prescribing and the front door in terms of liaising with the local community or doing some of that identification very early on in terms of what was needed. So having those discussions with the community in terms of signposting people to the available services. There was an example around vaccination and doing that with discrete groups. And the lady herself was able to speak Portuguese. So she was given an example of how the work that she's done on a small scale in terms of that cohort of individuals has been helpful, but it's about being able to sustain that. I don't know if anyone else in the group wants to add to what I've said, but no.
Yes, just a keynote. So I'm Gabriella, Community Outreach Officer for Northwest London, Brent Council, local prescribers to the picture. Why they are the key partners when it comes to support GPs. And another key point that I stressed on in the group chat was about the data that we've got so far. We need to think about the newcomers into this country. We support refugees, people seeking for asylum. We support individuals who do not have the right status, and they come with complex needs, with different health issues. So it's important for us to have a holistic approach to this topic. It's not all about our present residents. It's all about the newcomers who bring different challenges. And the data is key. We need to review the data that we've got so far, and we need to bring in those people. So we do make approach. For the past 4 years, I've been allocated to delivering vaccines in the community. And what we do when we do not have any vaccines on site, we do make to approach, to direct, and to inform residents. So this could be a good approach. So thank you, Julie, for that.
Thank you. Chris, any reflection, just reflections on what Julie and the group discussed there, but then some final reflections from you before we move on to other colleagues.
Yeah, I mean, really interesting reflections from everyone, sort of, very aware of how easy it is to talk about care closer to home and to use these nice little sound bites, but how much harder it is actually working in practice locally to put some of this into reality. I guess just picking up on Julie's remarks about relationships again, maybe I'll just sort of one final thing on that is that I think something that's really powerful that I've seen in a few systems is where they've created opportunities for people to walk in each other's shoes a little bit, or to see the world through each other's eyes, and that can be so across different settings, hospital, community, primary care, social care, etc. So that and there are various ways of doing that. So it can be around kind of delivering joint training. It could be about the sort of MDT approach, joint appointments across health and social care, blended roles, having career pathways that give people, experience in working in multiple different settings. I think all of that kind of just and helps to kind of strengthen those relationships and sort of understand where colleagues from different parts of the system are coming from, and that can be really powerful.
Thanks, Chris, for your final reflections there. Can I just thank you so much for coming along today? And it's always great to have someone from the King's Fund come to these sessions. You're doing some great research and giving us some really great insights. So thank you so much for inputting today.
Thanks, Helen. You're very welcome.
Thanks everybody as well from the groups that were brave enough to come and give us some reflections. So that's really great. So hopefully now we're going to start to focus on how we start delivering some of this change. And we've got some colleagues from Sefton, Geraldine and Sharon. I'm going to hand over to them. I think they did their intros earlier on. So can I hand over to Geraldine and Sharon, and you can take us through your slides.
Thanks, Helen. I think Sharon's going to start.
Thanks, Geraldine. Thank you. Yeah. So, we did introduce ourselves earlier, and I did actually make reference in our breakout group. We talked about language and the use of language, and I did actually make reference to our out of hospital offer, which isn't really in the spirit of what we are actually trying to describe here. It's more around our approach to seamless system working and services for our residents. So we had a good conversation about that in the breakout session. So I'm just going to introduce Sefton as a place. So Sefton is one of 9 places in Cheshire and Merseyside. We are 2 CCGs and 1 local authority, which has come together. So historically we were Southport and Formby CCG and South Sefton CCG. So we've now come together as one place. It's a vibrant area, really diverse area, stretches from Liverpool all the way up to the tip of Southport, which is bordering Preston. So it stretches the whole coastline and has a very diverse population. So in Sefton, we've got 5 areas of the poorest 1% in England, and we've got 5 areas which is 1% of the most affluent areas as well in the country. So that just demonstrates how different the population is as we move down the coastline, really. We've got an ageing population, so particularly in Southport and Formby, we estimate that we are 20 years projected in the future in terms of the number of frail elderly patients that we've got. And certainly within our South Sefton borough, we've got some of the most deprived areas. We've got a high proportion of people who are living with long-term conditions. And we have a high incidence of mental health issues within Sefton. And we've got a real challenge with health and well-being as well, and improving healthy lifestyles and the quality of life for our residents. We've got 3 large acute hospital trusts in Sefton, with 3 very different accident and emergency departments. They all have their own individual challenges, and we interface with all 3 of those acute trusts with our partners. In Southport and Formby, we also border Lancashire and South Cumbria ICS, and so we've got to work through those differences with strategy and strategic direction to ensure that there is an equity of service for people. We've got a high proportion of unemployment, and we've got a high proportion of our community who are reliant on the benefits and housing support as well. So we've got a real health, social and public health challenge in Sefton that we need to continue to try and address. So next slide, please. This is, we've put this slide in really to demonstrate the variety of system partners that we work with. We've got an integrated commissioning support, an integrated commissioning approach in Sefton, and we work really hard to build relationships with all of our system partners. And to work collectively and collaboratively to develop services and build the services around the needs of the patient. So that is a shared vision for all of our system partners, and we try really hard to maintain that. And I think that we do really pretty well to do that across the acute and our voluntary sectors, our public health partners, and our community services and health and social care teams, mental health teams. So that's just a demonstration of the length and breadth really of our partnerships and our approaches to commissioning. Next slide, please. So some of the challenges in Sefton, we've got a growing ageing population, and we've got a high proportion of care homes in Sefton. So we've got more care homes in Sefton than the whole of Liverpool city centre, the whole borough of Liverpool. And that's quite difficult. I know Geraldine will talk about market management a little bit more later on in the presentation. But we've got a real issue with working with our private providers and jointly managing the costs of placements and some of the packages that our complex patients require. So in turn, that kind of gives us an issue with budgetary demand and inflationary pressures and costs as well. So we do have challenges with maintaining cost improvement programs. We've got again quite a diverse stretch of population in Sefton, and that comes with challenges in terms of attracting and recruiting workforce. So Southport and Formby is it's almost kind of right on the tip. So it's quite a distance to travel, and to try and retain staff and make that attractive for people to come and work is quite a challenge. So we do have vacancies within our workforce. We also have issues with developing pathways and across that whole footprint, because the needs of the individuals in Southport are very, very different from the needs in Liverpool. And so we recognise that even within our place, we've got differences of services that we need to provide to ensure that our services are equitable, and that we are inclusive of our population. yeah, so that just demonstrates the challenges that we've got in Sefton. We do work very, very hard together with all of our system partners to try and address that. Okay, next slide. So in Sefton Place, we've got an integrated place director, and we've got an integrated leadership team, which is both health and social care and public health. We came together to address some of the challenges that I've described in the previous slide, and develop a programme of work in which we can start to really address the gaps and the deficits that we feel that we collectively have for people in Sefton. And so we've got a team which spans acute trusts, the community services, voluntary sector, and within leadership across our health and social care system. We're quite proud of what we've been able to achieve in terms of bringing our governance structures together, and how we can work together to try and address the community side of our services, and that neighbourhood working, which we are trying to move towards, and making some really great inroads in there. So next slide, please. So we did quite a big piece of work together. A consultation across our communities and our system partners, and we interviewed and engaged with over 600 people in Sefton, to try and gauge where we need to be really, and this is the vision that we wanted to kind of engage our key stakeholders, but also our public with. And this is just some of the feedback that we got from that consultation, and that feedback which we took into our Better at Home programme, and which helped to inform the way that we developed the programme, which Geraldine will talk in a bit more detail. But the vision is that people are better at home and living and ageing well in Sefton. So better place, better practice, better people, plan, partners, better pound, and better performance. And some of the messages that we got from the people that we engaged with in Sefton is that they very much want to feel more supported at home. They very much want to stay at home. They value their time at home, and they value their time with the loved ones, and feel that the direction of travel should be centered around home, and that's what we used as our ethos really, which took us into the Better at Home programme, but also got that initial engagement and ownership from our system partners. So I'll stop there, and I'll just hand over to Geraldine. She can kind of describe the piece of work that we're taking forward.
Thank you, Sharon. So as Sharon's alluded to, we do work in quite a complex system, and I suppose this is the shape currently of the Better at Home programme. So almost we have two elements of transformation, obviously managing the market, and I'll talk a little bit about that in detail in just a second, but obviously making sure that we've got the right capacity, that services are integrated, but obviously managing that supply chain. Obviously, the other element of the programme is around agent and hospital to home. So some of the significant changes that are both nationally driven as well as sort of locally inspired. Some of the things that we recognise in our system that need a change and need some transformation. So they're the two sorts of enablement arms, if you like, of the programme. Of course, there's enablers that allow us to do that transformation, and it is about workforce. Sharon's already alluded to our struggles as we see nationally with recruitment and retention, but the geography and the distance, and obviously making sure community services are mobilised where they needed, gives us a challenge. Obviously, we've got an eye on quality assurance and best practice, and obviously more and more trying to use digital solutions as part of our service oversight as well as operational delivery. That's the structure of the programme. Next slide, please. So obviously some of the drivers that we're trying to address during the development of the programme and some of our solutions, and I'm sure some of these drivers might be applicable to your area. Obviously, we've got too many people accessing adult social care formally, and we believe that obviously targeting some alternatives to support and self-help would alleviate those long waiting lists. Too many people going into hospital and having escalated needs through extended lengths of stay and deconditioning. And again, that's driving up, obviously, the packages of care and placements that we see. Our solution is around commissioning more discharge to recover and assess and using a strength-based approach at the right places. Too many people end up in the wrong service, and Sharon's already talked about our vast supply of care homes across Sefton comparative to other places, which sometimes drives that flow into that capacity. So obviously we're looking at obviously the placements in bedded care, and I'll show you some of the data that we're seeing as a result of some of the efforts that we're looking at. But budget pressures, again, sort of across adult social care and the NHS is significant, and maybe we're not using best use of limited funds. And I suppose one of the big changes that we're making is obviously post-discharge, we're having a description rather than a prescription of care, with a community MDT making the decision where people can go, obviously working with those individuals on a strength-based approach. And obviously we can see in our system, I'm sure, as well as yours, that more people are attending the acute setting in significant numbers. So part of our redesign and programme that I'll take you through in just a second is around how we shift into admissions avoidance or even reducing that admission post-attendance, and how we can support people back into the community. Next slide, please. So where are we up to? So we started in earnest in June of this year, and I suppose these are the 3 phases of the programme. Obviously, phase 1 we've done, and we're entered into phase 2. We have rolled out a transformative care hub. We are part of the system in Liverpool, but our focus was on the Southport and Ormskirk site, which is part of NW Group. And obviously starting to control sort of the discharges coming out of Southport and Ormskirk Hospital, which is part of our patch, has the biggest proportion of the ageing population. We've had a look at the changes that were made as a result of that TOC development. And I'll show you the data in just a second, but what we've seen is reduced pathway 3 discharges. As a consequence, we've reduced spot purchasing, both from adult social care and NHS. And we've increased pathway 1 discharges. So we are supporting more people to go home, which is obviously part of the programme aspiration and objectives. We've seen no increase in readmissions, but we do recognise that we have a gap in P1 capacity. So if we've shifted those patients away from long-term placements, we do realise, and it was always part of the plan, to grow that P1 capacity. And again, I'll talk to you about that in a minute. We've got a fairly sort of high number of P2 beds across Sefton, comparatively speaking to other places. So we're looking at how we use those to best effect. And again, sort of I'll give you a little bit more detail on that. And I suppose we agreed as a system home first expansion with some additional funding from NHS into community therapy and adult social care into reablement expansion, which is part of the plan. Phase 2 we're entering in will be around, we're just about to finish sort of recruitment, the providers finishing recruitment for that home first expansion, and we're looking at design and integrated reablement and therapy home first offer. So that's the focus very much of this phase 2. That will be mobilised towards the end of January, and we'll be looking to cap lengths of stay, which is a significant feature of some of the changes that we're making. Obviously, to sweat your assets, to get best use of the resources. Obviously, we need to move people from services into sort of their long-term placements or home, with the care that they need. So obviously length of stay is a key feature. We started a test to change in one of our bed bases yesterday. So again, cap length of stay, we're looking at skill mix, and we've broadened the criteria of how we use those beds. We've agreed as a system that we need to start to design an integrated brokerage function, and we're just about to embark on that design phase. And post April 25, we have some individual pots of funding that fund that D2RA space, so that intermediate bed-based space. We're likely to move that into the BCF under joint pooled arrangements. And as part of this piece of work, to make sure that we've got that maintained flow and the length of stay cap that we want to achieve, obviously we've done a piece of capacity requirement for social workers to make sure that we've got the right staff in the right place to facilitate that aspiration. From April onwards next year, we are going to procure an additional reablement provider to fill that gap in P1. We've got a new care home contract that will be live. Obviously, we'll further expand and add to that home first offer, bringing in digital solutions, voluntary sector, etc. But phase one of the home first mobilisation is about mobilising the incumbent providers, if you like, for those two individual services that currently fairly run in parallel and more isolation than we need. And obviously, we will be looking to mobilise that integrated brokerage function. Next slide, please. So market management, some of the things that we've done. We have actually engaged with our providers because it will be a change for them. And you can see the movement across the bottom of this slide. Obviously, we've published a market position statement and talked about some of the changes that we expect. We can see that some of the changes that we've made means that we've got currently a better capacity and sufficiency to manage demand coming out of the system. We've invested in digital. Obviously, we're looking at quality. There's been a restructure in the Adult Social Care Commissioning team with additional posts that work across health and social care. And obviously, we are beginning that integrated brokerage function. It's fair to say that the job's never done. There's further improvement that we need to make. And it will be about sort of affordability, cost control, which that integrated brokerage function should give us. And we can see, and I'm sure you can too, be interested to hear your views on requests for one-to-one care that are obviously driving up costs from providers. And obviously, transition is always a difficult pathway to manage. We need to focus on some of those pathway offers. And delivering the market position statement and making sure that we can see some of the movements in capacity that we want across the market. Next slide, please. So I think it's important to recognise your own complexity and some of the changes that you're making. And I suppose that was one of the key reasons why Better at Home was born, really. We recognised that there were several changes that are happening in the pathways and how patients move across the system. And we very much wanted to see that as a collective to make sure that we could monitor the individual impact and phasing of some of those changes. And anchor some of our local discussions that we needed to make with our providers into Cheshire and Merseyside's ICB recovery team. So we needed to make sure that we did what we needed to for Sefton, but obviously cognizant of what was happening across Cheshire and Merseyside. So this is just a little bit of the movement that we can see. Obviously, increasing admissions avoidance and post admission after attendance. Obviously, there's work going on internally to the trust around how they manage board rounds, etc., and get best use of individual clinical time. I've talked about the care transfer hub with the MDT, the community MDT making the decision on pathways and case managing those patients until they're placed. And then the changes in the supply in pathway 1, 2, and 3. Next slide, please. So just a little bit of detail around the transfer of care hub impact that we can see. We did roll it out in individual wards across the site in a fairly sort of fast pace. But I suppose what's interesting is the bottom table on this slide and the variance between 3 months worth of data before we rolled out the TOC and then after, and you can see the variance. So you can see in the numbers coming out of that system, the increase in P1 comparative post-TOC to prior to TOC, and obviously the changes in P2 and P3. So we monitor that quite closely, and obviously that informs our demand analysis and capacity plans. Next slide, please. Some of the system challenges that we faced, and I'll use the TOC specifically, but some of these are fairly generic IT systems. So we rolled out the TOC at a fairly fast pace against trying to mirror some of the electronic discharge implementation that was happening at the trust, because one would help the other. And the electronic discharge implementation has been delayed from the supply side. So obviously we had to use the old system. Running two processes causes difficulty and obviously consumes quite a lot of capacity to do that, and can add complexity. So obviously any changes that you're making rely on adequate communication across the relevant workforce. Whenever we start one of these changes, we often ask people to do the change on top of a day job, which is obviously a challenge for them. Obviously, that was our position in the early phases of TOC implementation. We've now commissioned the service in its entirety and added extra posts in to continue to deliver what we needed to. The significant transformation across multiple providers, and that is a challenge for us all. Obviously, we've seen the changes in flow that we wanted to see, but we recognised a delay in our increase in capacity in P1, so we had to use alternatives. Estates is always an issue and never ideal. The use of paper-based notes adds to the problems in communication, and obviously makes data collection difficult. And several programmes of work, as we said, were running across the system at the same time. Next slide, please. I suppose what do we believe were the success factors and some of the things that we've achieved? I think Cheshire and Merseyside undertook a system diagnostic prior to our programme, which gave us insight and common priorities across all system partners, with a clear aspiration that some of the things that we were hoping to achieve were part of the recovery Sentinel metrics. So I think that galvanised leaderships across providers and obviously gave us those common goals. So some of the things that Sefton wanted to do were obviously supporting and delivering the overarching ICB system priorities. We've already talked about on this masterclass sort of the importance of partnership and working and relationships. And I think Sharon's alluded to, there's good partnership working in Sefton. And I think that made things really better for us. Testing and phasing. I think you need to chop up your change. It's quite a big sort of change across the piece. And some things you will get right and some things you won't in the first instance. So the ability to PDSA cycle and obviously change things if they're not quite working alongside with partners, I think is important. Evaluation and impact measurements, making sure that you can see what impact you're having and taking that whole system approach. Obviously, communication is key, and obviously having the right staff involved in the right volumes with their involvement is a key feature. And I suppose, an example, when we rolled out the TOC, I think we did then ask the staff, how was it for you? And obviously there was some staff groups that weren't entirely happy with the change, but when we explained some of the impact that they were having, they became on board. So it's about that regular dialogue with staff around things that you're doing. And obviously asking the patients and users of the service. Obviously there was some finance that we managed to liberate and invest in the right places, but obviously looking at your existing resources, if there's nothing new, do you need to move some money around? And scope simplicity. Make sure that the changes are articulated in a defined scope, but recognise that they are connected and try not to boil the ocean. I think that's the last slide.
Geraldine, Sharon, thanks so much. I love your little phrases there, Geraldine. Boiling the ocean, sweating your assets. I've learnt some new things today. Thanks for that. You're hanging around because we will have an opportunity at the end of Sarah's presentation just for some reflections and discussion and a bit of a panel. Hopefully Chris is still around as well. But can I move swiftly on to Sarah and get a perspective from Manchester? Sarah.
Thanks, Helen, and what an act to follow. I feel slightly intimidated now to follow on the back of all of that. So thank you to Sefton colleagues. Before I get started, I guess it's worth reflecting that as we've talked through the session this morning, I've been a bit worried that I didn't get the brief right here, but I've decided, I've argued with myself and decided that actually I have got the right brief, because what you're going to hear from me is very much focused on change and transformation work that we've done in adult social care, specifically in Manchester, obviously in the context of integrated working and arrangements with health colleagues. And I guess the phrase care closer to home for me is just what we do in adult social care, isn't it? If anything, it's care at home. So I guess I just wanted to bring that reflection in and a bit of an explanation for why we're presenting why I'm presenting what I'm presenting. Before I get into the slides, and we'll move on in a sec, but just worth describing our arrangements in Manchester, our integrated arrangements. So I work for the City Council within adult social care, but adult social care is deployed into a partnership organisation, which is the Manchester Local Care Organisation. And you can see that on the logos on the slides, and that is a partnership between the City Council and Manchester Foundation Trust, which is our acute provider in the City of Manchester, but also provides community services as well as running the three major hospitals that we have here in the city. So we have very much delivered the change that I'm going to come on to describe in the context of being integrated with community health services in Manchester, but also facing into and supporting our acute colleagues. So just moving on to the next slide, Christina, thank you so much. So this is a bit of a snazzy slide, but it's an attempt to kind of describe our Better Outcomes, Better Lives journey. So as I said, we did come to one of these sessions a couple of years ago. I think it was maybe 2.5 years ago, if not more, when we were in an earlier stage of our journey. But just to set the context, really, that here in Manchester, we have a set of principles in our Manchester behaviours, that this was very much about translating that into the adult social care context. Everything we do in public services here in Manchester is about working together, focused on better lives for people, listening, learning, responding, continuous cycle, and that absolute focus on the strengths of individuals and communities, in that we always start from strengths. And then the right-hand side is just a bit about the kind of genesis of Better Outcomes, Better Lives. So we launched the programme in January 2021, which we may have all got some kind of collective amnesia now, but that was right in the middle of COVID. So it's worth just dwelling on that briefly, because obviously COVID-19 had a major impact on health and social care systems across the country and the world, actually. And I think the sort of discussion and debate we're having here today, it has probably driven a level of investment, activity, demand, behaviours across our system in a way that we haven't fully kind of appreciated yet, I would say. But certainly we did the slightly crazy thing, which was decided that we were going to do this transformation work in adult social care during COVID. At the time, we weren't sure how that would go, but actually, to the point about having capacity to deliver change within services, capacity was obviously very challenged, but actually doing this work helped to build resilience at a time when we needed it most. People want to make the services they deliver better. They want to work more closely with colleagues across a range of disciplines, and actually doing that in a strength-based, intentional way, I think really helped us to come through the pandemic stronger than we were at the outset. referring to just this kind of concept of having examples of how this approach improves outcomes. So really focused on, throughout the programme, describing case studies for real people and for our frontline practitioners around how we've made a difference, really strengthened the golden thread from sort of senior management all the way through to frontline practitioners through relationship building and working on developing our culture. So moving on. Thanks, Christina. So I won't dwell too much on this slide because it is a bit ancient history, but it's kind of useful context in that before we started on Better Outcomes, Better Lives, we had focused on getting the basics right improvement plan for adult social care, because we felt we really needed to make sure that we strengthened and enhanced the capacity we had in services. We've had years of austerity by that point, years more now too, but actually we felt we needed to really strengthen practice in order to ensure that we had the right workforce in place. Our workforce are our most valuable asset, and that's true of all services and systems on the call. And we needed to invest to be able to ensure we had the right foundation for change. I'll come on in a bit more detail around commissioning later, not to repeat everything the Sefton colleagues have said, but some similar gaps and challenges there. We did a piece of diagnostic work with a consultancy called Empower, who suggested that actually we did have a substantive opportunity to both improve outcomes, but also look at avoiding costs that we would otherwise incurred if we had carried on the way we were. And that is just through the basic concepts that are all very similar around prevent, reduce, delay. So moving on. So really, really basic slides. You can see we quite like basic slides here, but it was about building a service that supported people earlier and better. So that concept of care closer to home, but actually supporting people earlier. Embedding a strengths-based approach, and that we provide the right support at the right time. So not too little, but not too much either. Moving on. So the programme itself was structured as described. This is a bit more busy slide, so I'm not expecting colleagues to read every word in it, but we use this slide a lot to communicate and describe what we were doing to our workforce. So what are we doing? What's a long-term programme of practice-led change? Why are we doing it? Well, all the reasons I've already described. And then the how was around the kind of programme architecture and infrastructure. So we started with 6 work streams. We added on the safeguarding one latterly. So if I move on to the next slide, that has a bit of a kind of different way in of describing them. But the maximising independence work was about embedding strengths-based practice, essentially, across all of our services and teams. Early help, we've set up an adults early support team, so a whole new team at the front door of our services, which is focused and dedicated on supporting people to not need to be pulled into our services for a Care Act assessment, essentially. That's worked really, really well. And I'll come on to the impacts a bit later on because we have got evaluation across all of these different areas. The short-term offer was very focused on technology-enabled care, but also substantively reablement. So we have a very large in-house reablement service here in Manchester, which has enabled us to be able to flex, expand and grow that over time. And it has really fantastic outcomes and very much supports the work that we do to expedite people to go home in a timely way on discharge from hospital. See and Solve was very much about kind of getting into problem solving mode and trying to fix some of those system barriers that get in the way. So whenever you talk to, and everyone on this call will know this, if you go and talk to teams and services about change, they'll say, that's very well, Sarah, you want to do those things, but can't do it because this thing doesn't work in the system, or actually we haven't got the right provision out in the community, or actually senior management don't ever listen to what we say anyway. So it was about trying to get together with frontline practitioners to actually fix issues. And we had a tool that we used and we still use called My Views, which is where when practitioners were doing an assessment or another intervention, they could feed back to us on what might have made that work better or what the issues were. That a lot of that fed into our commissioning work, which I'll come on to. So responsive commissioning, the word responsive very much being about commissioning's there to respond to the support needs of our citizens, and actually our frontline practitioners are the best people, apart from the citizens and carers, to know what those are. And so we very much tried to turn around our commissioning function to face into frontline practice, as well as quite a lot of work to expand and reorganise that function. So part of that is that we have a very substantial brokerage function now that sits within what we call a control room. It's a bit of a strange name for it, but it kind of came out from the COVID work. But the control room sort of sits at the centre of our services and is the place where all care packages and placements are purchased essentially and organised, and they have an understanding of capacity in the market. They are then supported by a contracts team, strategic commissioning teams that work across the different functional areas, and a performance, quality and intelligence team that support ensuring that the services are delivering as we would want them to be. Also, as part of this work, we did a lot of work around market sustainability, as well as focus work on our fee uplift model and how we've ensured that we've brought substantive fee uplifts into the market. Slightly worried about April, just to put it out there, with the national insurance increase, just while I've got the opportunity, but that we'll see where we get to with that. Is my connection okay? I'm conscious that, Helen, can you hear me? It's saying unstable network connection, but
you've come back. There was a little bit of losing you and your voice, but I think you're back now, Sarah.
Okay.
So carry on. I'll let you know if there's any problems.
Right. Just let me know if you lose me. You can just fill in, Helen. You've probably had this about 17 times before.
You're picking me up too much there, Sarah.
The finance and performance work then just very much underpinned all of this, because one thing we've found is that to give confidence in the system around adult social care, I think one of our Sefton colleagues mentioned that we've got all these coders in hospitals, or someone mentioned that, one of the feedbacks from the discussion. We've traditionally been a bit on the back foot on finance and performance and data and intel in adult social care, I would say. Well, no longer in Manchester, because we've put a lot of effort into being able to describe the impact of what we do, but also to understand where our demand pressures are and how our activity is changing over time. Because the reality is, despite doing all of these things, demand is still increasing and activity is still changing, and we have to adapt our services to respond to that. So the more intelligence that we've been able to gather and collect and evidence has been really helpful in putting the case that actually we should be a respected partner in the health and care system, and we certainly are now. So moving on. This is a little bit about, so the Better Outcomes, Better Lives programme has officially come to an end, and I'll come on to the impact shortly. We've now moved into what we're calling Achieving Better Outcomes Together, which is the next phase of our transformation work. There's lots more detailed slides that sit behind this, but I guess it's worth just reflecting that we're moving from a strength-based practice to strength-based system, and part of that work is very much about working together with acute colleagues on responding to similar diagnostic work, Geraldine, that you mentioned, that occurred in Manchester, as happened in Sefton, and delivering on some of the outcomes of those, as well as all the work we're doing in the community, the work we're doing to strengthen our commissioning practice. We're doing quite a lot of work in mental health services and so on. Underpinned, it's important to note, around quite a focus on co-production. So I've talked about who knows best what people need. Well, the people who we support ultimately, and we have recognised that we needed to do more to co-produce and work together with citizens on outcomes. And we've now got 2 co-production coordinators who are helping us with that work. Moving on then, I think the next bit is about, oh, have I gone again? Have I gone again, folks?
You did earlier, but only for a second, Sarah, so just plough through, I would suggest.
Very strange. My connection is great. I think it might be because MCC does not like Zoom. It might be punishing me for using Zoom, possibly. Anyway, I'll keep going. So impact. So we go on to the next slide. There's a few slides in here. So we've done quite a lot of work about trying to understand the impact. And look, we all know that it's really, really hard to understand cause and effect when you're doing complex programs of change. So please do not believe that we have got this cracked, but we did believe that we could try to find some proxy measures that showed the impact of what we're delivering, and we're doing more work on this now going forward. But certainly looking at kind of benchmarked neighbours as well as other core cities and other neighbours within Greater Manchester, for the time period that we were working to, we felt that we had been able to manage demand in a way that was as effective as we would like to have seen. So a slight downward trend during the period of the programme. We are now seeing that come back up, and so we're trying to work through and understand if that is a lag in demand, is there a COVID impact there, and where that demand is coming from. But certainly we were able to manage and suppress demand through the work that we'd done. Moving on to the next slide. Everyone cares about money. So during the programme was initially intended to deliver savings. What we have been able to evidence, and I'll come on to that shortly. Have I crashed again? No, I can see you moving. Okay. Is that whilst we've had growth into the budget, the demographic trends relating to long-term care meant that we were effectively avoiding costs through the work, and that is described in this slide and subsequent slides. A lot of the investment that we've had into adult social care in the last few years has been directed entirely at the care market in order to be able to maintain market sustainability, and we believe that's been the right thing. There will be a limit to that, though, of course. Moving on then, and I'm nervous about the connection now, so I'm just going to be super quick. So this is just another way of looking at our proportion of spend on adult social care and how that differed from comparable authorities across the country, so being slightly below the average, suggesting that work, it's another proxy, isn't it, for suggesting that the work that we've done had a positive impact. And then towards the rest of the slides, I think if we can move on, Christina. There's a slide each on some of the impact that we looked at across the work stream, so I'll very quickly whiz through these. We are sending all this out, so never fear, you can read the detail in your own time. So strength-based practice, we did see a shift in home care hours from the community as a result of this, and we've got some lovely quotes in here from some of our colleagues as well around the impact that it's had on them. Then moving on. This is around our, just go back one, Christina, sorry. This is around our adults early support team. So key metric here was around the number of calls being resolved by the ACE team, which hadn't ended up going on to our long-term team. So that was 67% when we produced these slides. Moving on. So tech, our work on tech, I mean, we've probably had specific sessions on tech previously, but our work was very focused on ensuring that tech was being considered by frontline practitioners as part of support planning. And that was one of our metrics, is understanding, has it been considered as a starting point for making sure that we are utilising it in an optimum way. As I've said, we're doing more work on this now as part of the next phase of our work. Moving on. So reablement is a really big success story for us. So 74% of citizens leaving reablement needing no further care or reduced care. Actually, last month, so these aren't as up to date as I would like, that was even higher than that. I really would always advocate for a reablement offer. We're doing more work now to expand it to include occupational therapy, etc. So there's lots more work that we are doing. We're also doing an expansion into and more of an enablement offer for younger adults with a learning disability and mental health issues, again, as a means to looking to prevent or reduce the reliance on long-term care and support. Our modelling has suggested that this has avoided costs of 23 million over the 3 years of the programme, which is, we're quite happy about that. We're grateful that we've been able to achieve that, but we know we could still do more, actually. So further growth is coming. Moving on. Extra care is another area we've really invested in. So we've now got 12 schemes in the system. We've got more coming on stream. Could talk about this all day, but this has been really helpful and supportive in our work with hospitals, particularly around dedicated apartments within our extra care schemes that are neighbour apartments that we can use to support people when they exit hospital with support from reablement, as well as ensuring that we've got that step up, step down model in place as well as an alternative to residential care in particular. We do have some dementia specific schemes as well. So moving on. Oh, and this is the last slide, thank goodness, because I know we're going to run out of time. So we think that what we've done has led to improved outcomes and helped us to manage demand and spend. What I would say, though, just to reiterate, is that we haven't got this sorted because we have got all the same challenges that everyone else has had, and this is a long-term journey that we're all on. So I'm really grateful for all the inputs I've heard from other colleagues today. So thank you to Sefton colleagues in particular, because you've a couple of things that you're doing that we will be stealing. So thank you.
I think we call it pinching with pride,
Yes.
Sarah. Thanks so much, Sarah. That was really, really great presentation. And I think I did see an earlier iteration, but obviously what I've seen now is real progress in what you've been doing. So that's really great. I really liked a couple of things I really liked in there was around that you're listening to your staff, because obviously staff have got loads of solutions, haven't they? And you're trying to listen to what they do and do something about their sort of feedback and impact and input. So that sort of see and solve, I really like that. It was great. And obviously the big improvement in your data as well in this area. Sounds like it's been a, sort of a journey, but you're kind of getting there a little bit. So thanks for that. And thank you for Sharon and Geraldine again. And I think we've got an opportunity now. We've probably got about 10-15 minutes to maybe get some reflections and discussion going from colleagues on the call. So first of all, can I see if there's any questions from people on the call? Not sure I can see any hands up at the moment. Anybody brave enough to jump in for a comment? Kenna, you're saving the day here, Kenna.
Honestly,
well done, you.
Probably like everybody on the call, you're trying to jump and deal with. I'm frontline operations, so trying to deal with things. I'm particularly interested in what Sarah said around extra care developments, and I think it's sort of and that statement you just made about pinching with pride has got me around, the step up, step down into extra care. So I might well contact you about that, because crazily enough, we've got an extra care scheme that we've opened 102 beds in, and we're not quite filling it up. And it seems crazy, doesn't it, in some way, with the lack of housing opportunities in the community. So I might come back to Sarah on that, but the two presentations I've heard, both from Sefton and from Sarah, great in terms of pinching with pride. I'll be looking forward to getting those slides. Thank you very much, guys. Thank you.
Thanks, Kenny. Chris, are you still on the call? Just wondering whether you've got some reflections, because at the start of the session, obviously you gave us a load of challenges that sort of systems are facing, and actually we've heard from two areas where they've got not a complete solution but a part solution to things and on a journey. So just wondering from your perspective what your reflections are of those two sort of presentations.
Well, thanks, Helen. I don't think I'm going to kind of add anything particularly profound, but just, I mean, it's really great to hear both the presentations, and they do illustrate that, despite the difficulties, we can make some progress on this agenda in different ways. There are two different examples, but with some kind of common themes about how to go about the process of change, I thought. So really great to hear them, and well done for everyone involved in sharing that work.
Thanks, Chris, and thanks for the input. Just from my perspective, if I might indulge myself a little bit as chair, it would be good for us, I think, just to get some deeper understanding from the two places that have delivered the presentations today about the first thing around relationships. You both covered things around how you get the relationship right and how you get your culture right. So I'm just wondering if I could come to maybe Geraldine and Sharon to say, how are things in Sefton around sort of relationships? Because that seems to be a critical factor in getting things right.
Shall I start, Sharon, and then?
Yeah, and then I'll come in.
I think we started on a solid foundation. Of course, I think it's about honesty and involvement to maintain the relationships. Obviously, they are person-centric, aren't they? Often. So I suppose it's about having honest conversations, and some changes that you want to introduce are better or worse for various organisations. But I suppose it's remembering what you're looking to achieve. I think sort of holds the relationship together. And I think that's my takeaway. You know, some of the changes that we've made haven't been as easy for some parts of the system. But obviously,
could you just describe that without giving too much away or offending anybody in any great detail? But could you be a bit honest about what some of those difficult conversations have been?
Yeah, I mean, the transfer of care hub almost takes the decision away from the acute trust on the pathway of discharge, doesn't it? That's the purpose of it, to recognise from a community perspective, what people can do in their own home. That sometimes is overprescribed if you're looking at it with an acute lens. So that was particularly difficult for the hospital therapists, I think. They obviously post-COVID had been making decisions based on what a patient can do in hospital, on what they need at home, and probably those of us that work in the community recognise that that's a completely different scenario, isn't it? Every home's different, and what people are willing to do in the home and what they'll do on a ward sometimes is a million miles apart. So the community therapists were particularly challenged about, from their view, losing the decision making and querying their professionalism and interpretation of what a patient needs. But obviously, we've overcome that. Obviously, there was engagement in the beginning, but they still didn't like it. But actually, once we've showed the impact that we've done, actually we've involved them in the top discussions, etc. They get it now. So obviously they've bought in. I suppose another example is the bed base that I referred to, that we're doing the test of change. Historically, it was almost sort of a split unit, with the trust having admission rights for some of the beds. We've now brought that back in through the MDT in the TOC, with the trust obviously part of that decision making. That was quite a challenge for them, and I can see where the trust are coming from. So from an acute perspective, quite often we've got intermediate care beds, but with vacancies, and yet they've got ambulances queuing at the front door. Yeah. So actually, that's quite a challenge, isn't it, to lose that sort of admission right to some of those community beds. But we're doing a test to change. They're involved in the decision making. We're broadening the criteria, and we're going to obviously monitor the impact. So they're two specific examples.
Yeah, brilliant, really great.
Could have challenged our relationship.
Yeah. And I think it describes, doesn't it, people giving away their power in some respects for the greater good, and actually using data to say these are the outcomes. That's a really great way of demonstrating it to people that might be struggling a little bit. What about Sharon? Have you got an example? And then I'll bring Sarah in.
Yeah. So I've been in on this. I've been in Sefton a long time, and we've gone through a lot of transformation over the years. Probably not unlike the guys on this call. I would say relationships and culture, as on a whole, not just specifically within our Better at Home programme, has changed significantly since the pandemic. And I know Sarah,
in a good way, Sharon, or in a bad way?
Yeah, well, I think there's been there was an element of like, kind of, come on, we're all in it together, and there's some well-established, mature relationships relationships. But since the pandemic, there's been a lot of organisational change. So, for instance, our two big hospitals, Luft and the Liverpool Royal and Aintree, became Luft. MWL is now Whiston and Southport and Ormskirk. And so there's been a lot of organisational change, and of course the CCGs into ICBs, and then setting up the places. And we're two CCGs that have come together.
Yeah.
But I think fundamentally, those strong relationships are still there. And there's a recognition that we all just kind of like rolled our sleeves up and got on with it through that. That's probably strengthened some relationships, but brought in new people because of the organisational changes. There's a lot of new ideas and a lot of a lot of strength-based kind of mature ways of wanting to take this programme forward, but also some challenges with new people who have got new ideas, which is always great. Culture, I think, is a big one, because I think internally, our two big hospitals, MWL and Luft, are probably struggling with culture internally because they've got a mixture of new staff that have come in through the mergers. So there's a lot to contend with at the moment, especially now with the new kind of Darcy report and the new kind of move towards, right, okay, how are we going to bring this out of secondary care together, including secondary care, thinking about the way you work, thinking about how we can kind of bring the patient closer to home. There's a lot going on, Helen.
Which is what I think Chris was describing as like things that we don't need anymore, is maybe more reorganisation, given that the sectors, health and care have gone through huge changes sort of recently. Sarah, I'm just wondering if you've got any thoughts around relationships and how that's going in Manchester.
Yeah, so I was going to say some of what Sharon's just said, actually. I do think that the ICB changes more recently have just thrown us into another sort of transitional phase. And we all know that when you're in transition, it's difficult, isn't it, to concentrate on thinking forwards and delivering change, and that relationships can suffer just by virtue of people leaving the system and arriving into the system. So having continuity of partnerships and relationships is quite important, isn't it? Obviously it's great when new people arrive and people do new things, but I think possibly that's been a bit of a challenge for us. I would say the relationships within the kind of LCO construct that I've described continue to be positive, and we are seen as that trusted partner, I guess. It is always interesting when you're in adult social care, because the local authorities, of course, our structures haven't changed, and so we kind of are,
depends which local authority you're in, to be fair, Sarah. I think
fair enough. I guess the principle being that the local authority is a different organisation again, isn't it, from the NHS, and so hasn't had such a lot of turmoil at a macro level, notwithstanding at a micro level there might have been.
In the region, though, we've had local government reorganisation in Cumbria, so that you could see from a different system that's been a really big challenge. Anyway, just one final question to all of you, and maybe I'll start with Sarah first, is hopes for the future. What are you hoping will sort of change maybe in the next 12 months? Very quickly, if you can. Running out of time.
I'm really hopeful to see what comes out of the NHS 10-year plan conversation that is going on, and then following from that, anything that comes out around adult social care reform, and that alongside all the work that we're already doing at a local level and working really, really hard on to improve outcomes for the people we support, that opens up a national dialogue that reflects the dialogue that we've had here today, and a recognition that the way we're doing things now needs to fundamentally change to bring care closer to home in the way that Chris provoked us with at the beginning. And I think the 3 shifts and the rhetoric at the moment is pointing in that direction. So I'm hopeful that in a year's time we might be starting to see the fruits of some of that.
Thanks for that. It's great reflection. What about going to Sharon and then Geraldine?
So I'm hoping that we are going to continue on this improvement journey and utilise some of the learning that pushing each other out of our comfort zones, as Geraldine described, across boundaries, that actually thinking differently about the way we deliver services can deliver excellent outcomes for people. And patients, and I think certainly there's green shoots of that, because we have almost kind of gone on a journey where we're saying, no, you could do that, you can deliver that over there, because the test of change that Geraldine was talking about is actually the trust coming out of the 4 walls and doing what they do within our community setting, and they can see now how quite easily doable it is, So I just think being brave, as Chris rightly articulated. So be brave and let's do something different that actually almost breaks the mold to see if actually that's the right thing for people. I'm really hopeful, to be honest, in terms of the new legislation that's come out. I'm excited about what we can achieve.
Thanks, Sharon. And Geraldine, final comments from you?
Yeah, I hope, Helen, we held our nerve. We are on the beginning of a journey. Chris talked about before, this mightn't actually be cheaper, but it is better for people and the system. So I just hope we get the time to deliver some of these changes and then obviously see the impact, because there is a lag and some of these changes aren't quick. So I'm hopeful we hold our nerve and the 10-year plan gives us that space to do that.
Thanks so much, everybody. So thanks, Geraldine. Thanks, Sharon, Sarah and Chris. I think it was a great session. Thanks for provoking some challenge in us, Chris, from the King's Fund. It was really great, all the presentations that we've had. So we're just sort of coming to the end of the session, and just wanted to thank everybody in the call that sort of participated. We have got an evaluation of this session, so there's a link, I think, that's going to be put in the chat. Really helpful it only takes a couple of minutes to complete, and it really gives us some insights about what you're thinking and what we could develop in a masterclass in the future. So it'd be really helpful if you complete that. I think we've also got the next masterclass on the 5th of February, which is cultivating a social value mindset. So really looking forward to that. So hope to see everybody on that session in the new year, and wanted to wish everybody happy Christmas and happy New Year. I hope you have some much needed break over the sort of festive period, and happy to take any final comments from anybody, or if you want to post something in the chat, we'll pick that up as the part of the evaluation as well. Thanks everybody for attending.
Thank you. Thanks, Helen.
Thank you.
Thanks.